Hello and welcome. I am Dr. Professor Rahul Kawatra, Professor and Head ENT, and today I am going to talk about the history taking of a nose case. So, as we all know, that whenever we have to take the history, for that matter, whether it is history taking of an ear case or a nose case or a throat case, there are few certain points which we must keep in mind before we start. So those important points are that the history is to be recorded in the words of the patient. Now here I have a little extra suggestion, and that is that you have to record the relevant history, not the irrelevant history, because seeing the socioeconomic status and the intelligence of the patient, we as the doctors should be able to identify what history is important, which needs to be recorded, and which will help us in the examination and then finally the diagnosis of the case. So with this note, we proceed with the important points which we need to take care when we have to take the history of a patient who has a nose problem. So let's begin. Okay. So let's begin with the first part that we need to understand is the patient particulars. And in the patient particulars, we need to record the name of the patient, the age of the patient, the sex of the patient, the occupation, and the address. So as we can see that in the age, we can see that there are certain things like meningocele, choanal atresia, foreign body nose, and the anterior epistaxis, which is more common in the pediatric age group. And similarly, in the adolescent, you can find that juvenile nasoangiofibroma, which is also called as JNA, antroconal polyps, they are more common in the adolescent age group. And in adults, things like ethmoidal polypi and rhinitis and sinusitis and malignancy, these are more common in the adults. Similarly, recording the sex of the patient, the males are more predisposed to nasopharyngeal carcinomas and sinonasal malignancies, and in females are more predisposed to atrophic rhinitis, especially where the secondary variety, which is correlated with the hormonal imbalance that happens in the during the phase of pregnancy or post-pregnancy. The occupation also gives us an indication about the certain problems like sinonasal malignancies are more common in woodworkers, and exposure to dust will definitely lead to allergic rhinitis. Then certain coastal areas patients are more predisposed to a granulomatous condition called as rhinosporidiosis. Okay. So once we have recorded the patient particulars, we go ahead and take down the chief complaints of the patient. Now, point to be noted in the chief complaints is that it has to be taken down in chronological order, and generally not more than 2 or 3 complaints, the chief complaints which the patient has, for which the patient has actually come to your outdoor to consult the doctor, that has to be kept in mind and that has to be recorded. Okay, so here comes the importance of taking a relevant history. Okay, so that is what it is. So important problems which generally a patient of nose problem will come to you are as such the nasal obstruction, nasal discharge, and we'll go one by one. And another thing that I need to tell you is that in history of present illness, once you are elaborating the chief complaints, you have to take down certain points like the onset of the disease has to be seen, the course of the disease has to be kept in mind, the duration has to be kept in mind, and certain aggravating and relieving factors, that also has to be kept in mind. Okay, so based on this, all the complaints are elaborated. So let's come on to the first complaint, which is very common in a patient of a nasal problem, is the nasal obstruction. So you have to first uh, see whether the patient has got a unilateral obstruction or a bilateral obstruction, and based on that you have to keep certain causes in your mind. And I have just written a few causes, like unilateral obstruction is more common in foreign body nose, rhinolith, antroconal polyps. As long as the antroconal polyp stays within the nasal cavity, then a C-shaped deviation can cause unilateral nasal obstruction and unilateral choanal atresia also. So patient will give you a characteristic history that one side uh, nose is blocked and the other side the patient feels okay to breathe with. Okay, and then bilateral nasal obstructions are more common in ethmoidal polyps, deviated nasal septums where there is compensatory inferior turbinate hypertrophy that has happened. Then in S-shaped deviations where the deviation is on both sides of the nasal cavity, the patient will present as a bilateral nasal obstruction. Then cases of septal abscess or septal hematoma also present with bilateral nasal obstruction. And another cause, the nasopharyngeal causes of bilateral nasal obstruction are the adenoiditis, which is very common in children. You will have children coming to you in OPD who are mouth breathing, and parents complain that their son or their daughter is not able to breathe from the nose. And juvenile nasal angiofibroma, advanced sinonasal malignancies, antroconal polyp where the polyp has gone down into the choana, and bilateral choanal atresia. So these are the various issues where you find bilateral nasal obstruction. Then next, we come on to another important complaint that the patient gives to us is the nasal discharge. Similar to nasal obstruction, we need to keep in mind whether the discharge is unilateral or bilateral. And then unilateral, very common MCQ that comes is the foul smelling discharge in a child. Okay, so that is very common and you see it in foreign body nose. Young adults who have antroconal polyps will present with unilateral nasal discharge with nasal obstruction, and even in cases of rhinolith. Bilateral nasal discharge, similarly, just like nasal obstruction, is present in deviated nasal septum with inferior turbinate hypertrophy, ethmoidal polyps, which are bilateral in nature, then allergic hypertrophic rhinitis, where both sides turbinates are enlarged and the patient gets secretory discharge, which is serous or maybe mucoidal or maybe sometimes mucopurulent if it gets infected later on. Okay, so another important point that we need to ask about the type of discharge, whether it is serous or watery. This kind of discharge is generally seen in allergic rhinitis or vasomotor rhinitis. Then the discharge which is clear fluid like. Now here we have to be very careful in taking down this history where the patient says that the discharge is clear fluid or maybe just like tap water flowing out in a gush. So such cases can have CSF rhinorrhea. So we have to keep it in mind that if the patient is giving you a history that there is clear water-like discharge that comes and it comes in a gush, and if you elaborate on it, then maybe the knowing what is called as the halo sign, where we ask about whether that thing gives a halo when it is seen on the when that drop comes on the handkerchief. So this is a handkerchief test, or the halo sign is what we see on the handkerchief, that there is a halo of secretion which dries around it, and in the center there is some blood clot present. So this is the kind of discharge that you get in CSF rhinorrhea. And another important thing about this discharge is in the handkerchief test that the handkerchief does not become hard. So there is no crusting, or there is no tightening of the handkerchief, which is there in cases of allergic rhinitis, where you have mucoidal discharge, which dries up and makes the handkerchief a little stiff. Okay, and then mucopurulent nasal discharge is commonly seen in infective rhinitis or maybe sinusitis also, and purulent discharge is commonly seen in furunculosis or septal abscess, or maybe a foreign body nose in children will give a purulent foul smelling discharge which is unilateral, and that is diagnosis as foreign body nose in a child. And then you have to specifically ask for the history, whether the blood stain is there in the discharge or not, because you can suspect, if you're suspecting a foreign body or maybe some granulomatous lesion in the nose like rhinosporidiosis, or in an elderly patient if you are suspecting a malignancy, then the discharge will be blood stained. Okay. Then after the nasal discharge, another important complaint the patient can have, or we have to ask, is whether the patient has got any headache or facial pain. Here the history of pain, the area where the pain is happening and its relation during the day is important. And common causes of facial pain or headache from ENT point of view, specifically a patient with a nasal problem, is acute sinusitis. Okay, and this can cause pain and heaviness in the region of the sinus involved. And just to give you an example, maxillary sinusitis pain is generally infraorbital and in the malar eminences or in the cheekbone area, and it increases during the day. This is very characteristic of maxillary sinusitis. Similarly, ethmoidal sinusitis, the pain will be referred in the area of the nasal bridge, underneath which lies the anterior ethmoidal sinuses, and in the inner canthus of the eye area. So the location of the pain, where the patient is having pain, is also very important. And similarly, the frontal sinusitis, it's in the forehead region, and there is a classical what we call is as the office headache. Now, office headache is something where the patient complains that the headache starts in the morning, when the patient wakes up, it peaks during the office hours, that is during the daytime, and in the evening it subsides. Now, that is the reason why it is called as an office headache, because it is during the office timings. And in sphenoid sinusitis, the pain is generally located in the occipital region or in the retroauricular region. All right. So then another important pain that we know of is called as anterior ethmoidal neuralgia or Schluder's neuralgia, and that is where, when there is a septal spur and if it is impinging upon the middle turbinate, it will cause the pressure on the anterior ethmoidal nerve, leading to a pain in the area of the eyebrows and down to the nose area. So this is called as Schluder's neuralgia, and you can be asked by the examiner, what do you mean by Schluder's neuralgia, especially if you are presenting a patient who has got a nasal problem. Okay, so you have to specifically ask for these problems. Once you have completed with the chief complaints, if the patient does not have them, then that's a separate issue. Then you have to note down that the patient does not have pain in the nose area or like that. Okay, Then another important complaint with the patient comes is frequent sneezing. Now, sneezing is basically a protective mechanism, and it is very common in patients who've got common cold or allergies. So it's clear-cut, straightforward history that you have to present that the patient has got sneezing or not. And another important complaint that we must look into is epistaxis or bleeding from the nose. Now, commonly in children and in most of the people, the bleeding is from the anterior inferior part of the septum, which is called as the Little's area, and the plexus that is formed is called as the Kisselbach's plexus, and it is a plexus which is an arterial plexus, and it is formed by the septal branch of the spinopalatine artery, the anterior ethmoidal artery, which comes from above, and the greater palatine and the superior labial, which comes from below. So you've got sphenopalatine, anterior ethmoidal, greater palatine, and superior labial, and I commonly write as SAGS, SAGS, SAGS. So, sphenopalatine, anterior ethmoidal, greater palatine, and the superior labial, which forms the Kisselbach's plexus, I'm sorry, and which is an arterial plexus. And the area is called as the Little's area, from where the bleeding happens. Another important area is the Woodruff's area, which is basically a venous plexus present at the posterior end of the inferior turbinate. Now, this is the difference from the Little's area, and it is a common site of bleeding in the elderly and in the adult age group, and the common reason for it is hypertension. So there are various causes of epistaxis where we will discuss some other time in detail, but this is a brief outline which you have to keep in mind when you are recording the history of this patient with a nasal problem. Then the patient can have certain smell disturbances like hyposmia, parosmia, cacosmia, and anosmia. Now, hyposmia basically means the sense of smell is diminished, and it commonly happens in patients who are in the menopause age group or the females especially, and the patients who are subjected to radiation therapy or in old age or post surgery can have hyposmia. Okay, and then we have altered sense of smell that is called as parosmia, which is common in fractures or intracranial tumors. Okay, cacosmia is what is called as bad smell, and it can be present in foreign body nose, sinusitis, or in malignancy. And complete loss of smell is seen very commonly nowadays in COVID infection. So we have to take this history also, anosmia or loss of smell, or maybe sometimes hyposmia can indicate this COVID infection. So this is one of the very important complaints. Maybe sometimes patient might just come with one complaint, that is loss of smell and no other complaint. So we have a high suspicion that he has had a COVID infection. And then this can happen in trauma of the skull base or in other olfactory nerve tumors. Okay. Then another complaint that we need to look into, certain patients who have snoring, which is an abnormally loud sound while sleeping, which is generally due to the vibration of the soft palate, and it is the laxity of the soft palate which leads to the sound. And this history is invariably given by the person who is sleeping with the patient. In children, the commonest cause of snoring is adenoid hypertrophy, and in adults, patients with severe deviated nasal septum or gross nasal polyposis, where there is almost near total nasal obstruction and the body is compelled to breathe from the oral cavity, sooner or later will land up with the problem of snoring. and it can also happen in hypertrophic turbinates. Then something which is similar, the underlying condition, snoring is a presentation, but it can indicate a problem which is called as sleep apnea. Sleep apnea is basically the temporary cessation of breathing on which is during sleep, which is called as apneic spells, and any more than 5 episodes of apnea during 1 hour's period of sleep is considered to be significant. And you have got various ratings as mild, moderate, or severe apnea based on the number of apneas that we have during an hour. It can be 5 to 20 in mild, it can be 20 to 40 in moderate, and it can be severe apnea in more than 40 episodes of apneic spells if we have in an hour, which lasts for only few seconds, but there is a temporary cessation which is markable, especially told by the patient's attendant who sleeps with the patient. The partner has to tell the history, and you must ask the patient's attendant if there is any history of snoring or sleep apnea, because nowadays this is a very common cause of morbidity as well as mortality in adult age group. So any patient with nasal problem, we must look into the aspect of snoring. And then the patient himself or herself will give the history of daytime sleepiness, lack of concentration, extreme tiredness, and maybe interference in the day-to-day activities. So the patient of sleep apnea will come to you with the history of daytime sleepiness, difficulty in breathing from the nose, and frequent falling off to sleep during the daytime, and a feeling of tiredness. So this will indicate maybe a central apnea or an obstructive sleep apnea. Okay, uh, so details we'll talk about later. Then another important complaint that we must look into is the change of voice. So there are only mainly two where there is hyponasality. This is called as rhinolalia clausa, where there is a decreased nasal twang. So it's a muffled voice that comes generally in cases of total nasal obstruction like adenoids or nasal polyps or nasopharyngeal angiofibromas. Then there can be hypernasality, which is rhinolalia aperta, and there is the increased nasal twang. The patient will speak as if it is speaking in the nose. You might have found it can be natural tone of some people, singers like Mukesh and all used to sing in a nasal tone. So that does not mean that they had rhinolalia aperta, but it can be physiological also, or it can be pathological also, and pathological conditions is what we are concerned with. So it can happen in patients of palatal surgeries or cleft palate patients who had palatal palsy or velopharyngeal incompetence, or post adenoid patients or post polyp surgeries where there is the cavity becomes more roomy, the nasopharynx becomes more roomier, and the nasal cavity becomes more roomier, leading to the vibration of sounds in the nasal cavity, and the patient has got a typical hypernasal voice like क्या कर रहे हैं, कैसे कर रहे हैं. This is how the patient will speak like. That's just an example that I'm giving to you. Okay. Lastly, we come to another important complaint, that is the post-nasal drip, which again you need to ask the patient that whether do you have any feeling of trickling of secretions in the back of the nose or into the throat. This commonly happens in patients of rhinitis, rhinosinusitis, deviated nasal septums, and adenoid hypertrophy. So patient will give you a history कि गले में कुछ गिरता हुआ लगता है, कुछ सिक्रीशंस आते हैं और खंगार के साफ करने का मन करता है. तो ये चीज़ आपको पूछनी है. यू विल हैव टू आस्क द पेशेंट स्पेसिफिकली फॉर इट, and followed by the specific history, then you have to take down other negative histories, the personal history of the patient and the family history of similar problems. Okay, so here's the final checklist of the history of a patient who's got a nose problem, that you start with the patient particulars, followed by the chief complaints, which has to be mainly 2 or 3 chief complaints in a chronological order. The history of present illness is basically the elaboration of the chief complaints and also other complaints. So you start with nasal obstruction, which can be unilateral, bilateral, whether it is complete or partial, which is continuous or intermittent, or there is any history of injury or any surgery or upper respiratory catarrh or any allergy or any bleeding. So you have to ask, and you have to even look for that if there is any adenoid facies, especially if you are seeing a patient of a young patient or child, okay, who has a history of nasal obstruction and mouth breathing. Then a common history of nasal discharge, again you have to ask for the patient whether it is unilateral or bilateral. The nature of the discharge needs to be clarified, whether it is serous, watery, mucoidal or mucopurulent. I've given you the causes and I've told you the common causes of all and whether it's blood stained or not. Then the duration of the nasal discharge, the color of the nasal discharge, the consistency, the quantity, whether the discharge is anterior or posterior. We just talked about post-nasal drip, so that is how you tell. Ask the patient कि गले में कुछ उतरता है या नहीं, और क्या smell आती है नहीं, is it foul smelling or not, and other various aggravating and relieving factors which are associated with nasal discharge. So what time of the day, the diurnal variations and all can be asked. Then the history of headache, as I told you, you must identify the exact site, must be asked specifically where exactly is the pain, because that will indicate what we are dealing with, whether it is frontal sinusitis or maxillary sinusitis or ethmoidal sinusitis. So we need to know the exact site. Based on that, we can clarify what kind of problem we are dealing with, and accordingly we can do the examination. So then the type of the headache, the severity of the headache, and the periodicity and the diurnal variations of the headache, as I told you about the office headache, which is common in frontal sinusitis, that has to be found out. And associated complaints are like vomiting or decrease in vision or anxiety. These problems will indicate some other problem which may not be related to the characteristic headache that is present in the nasal problems. Okay, so it can indicate a complication if there is diminution of vision, because if the sinusitis is invasive kind, there can be the invasion into the orbital cavity because of the polyposis or the nature mucormycosis or anything. You can have a complaint of diminution of vision along with headache. Okay, and then as I told you, sneezing, which is a reflex mechanism, but you need to elaborate on it about the frequency, the timing, its relation to the seasonal or the diet or place, because that will indicate various allergies and the provocating agents or the aggravating factors that cause sneezing, and other associated factors in the negative history that you need to elucidate while you are taking a history of sneezing. Then nasal bleeding or epistaxis is important. You need to ask the severity, the quantity of the bleeding, whether it is large in amount or just streaking of blood. That will indicate how severe is the problem, because the patient can give you a misleading history of large quantities, but that needs to be clarified, whether it is a few drops or maybe it fills the entire handkerchief, or maybe more than 1 or 2 tissue papers are filled up. So that will give you a rough idea about the quantity of the discharge, because if the patient is terrified with the nasal bleeding, he or she may always tell you that the bleeding is copious in amount. So you have to spend time with the patient to clarify the quantity, and then you have to ask the history of trauma, hypertension, or any bleeding disorder. That has to be seen to rule out other factors which could cause bleeding. Systemic factors also cause nasal bleeds, so that also has to be ruled out to differentiate between the local factors and the systemic factors. Then aggravating and relieving factors, okay, and the relationship to the season or the diet. All these things are more or less common for sneezing and nasal discharge and everything, but you have to individually look into each complaint and uh, note down these particular points, and you have to present it in your history whether it is present or not present. So this is the checklist why I have given you that, so that you can note down each and everything in an order and make a checklist of it, and then proceed to ask the history of the patient and keep seeing whether you have marked all the important points in the history. That is what is taking a relevant history from a patient. Otherwise, the invariably the time is spent into misleading statements given by the patients, and which can waste a lot of time, especially when you are preparing or giving your practical exams. You don't get much time. You hardly get around 40-45 minutes to present your long case, and in that you have to take down the history, do the examination, and prepare your case so that you can present it in front of the examiner. And it is very sad that the students just don't calculate their time, and they waste time in taking history, and they are not able to do a proper examination, and they are confused at the time when they come to present the case. So this should not happen. You must keep yourself, time yourself, so that you can take a proper history, and once you have a checklist, you will not waste your time. This is why I'm trying to tell you every time that you have to take a relevant history. Then disturbance of sense of smell, as I told you, anosmia, cacosmia, and parosmia. We've already talked about the causes. That has to be looked into. The then another is snoring or obstructive sleep apnea. You have to see the severity, the disturbances of sleep, and whether there is any history of sudden awakening in the night or cessation of breathing in the night, and how badly does it affect the daily activities. So the history from the bed partner is very important. Bed partner is the person who actually sleeps with the patient, and that's the person who will give you the exact history about the snoring, because patient himself or herself is asleep at that point of time. Okay, then the change of voice, as we've already talked, whether it is rhinolalia clausa or rhinolalia aperta. So you have to record it in the history. Is there any change of voice or not? Then other associated symptoms, like important in the past history of trauma or any surgery or any medication, the personal history about alcohol, tobacco chewing, or smoking, or any other, and the type of occupation that the patient has, as I discussed about the woodworkers or the exposure to allergies, will give you an information with what kind of problem you are dealing with. Then a family history of allergies, tuberculosis, hypertension, diabetes, and malignancy also can help you in reaching your diagnosis. So we conclude here, and I hope you have been able to follow this presentation well, and I would in the end again suggest that you make a checklist of all the important complaints that you have to ask your patient, and then proceed with the history taking of the patient in the words of the patient. Okay, so thank you very much, and I hope to see you back again with probably the next lecture on examination of a nose case. Until then, goodbye. God bless.